Good morning, everyone. We're going to get started. We have four special guests here today. I'm Ann Wong, and I'd like to take this opportunity to welcome Mr. McIsaac and Dr. Michael Stacey to give us a few announcements before we start our rounds. So if I could have you come up, and thank you very much.
Hi, good morning, everybody. So I'm Rob McIsaac. I'm CEO here at Hamilton Health Sciences, and this is Dr. Michael Stacey, who is our Chief Medical Executive and responsible for lots of other things as well. But today, I'm not sure if you know how special today is. It's Doctor's Day, so we're here to say Happy Doctor's Day. But probably more significantly, we're here to really say thank you for all the work that you're doing here in the hospital. I do think it's a special time for us here at Hamilton Health Sciences in lots of different ways. We're kind of on the cusp of transforming the hospital in some really profound ways, and so I guess I would say we're going to have to prevail on your good graces to help us succeed in doing this, but probably most significantly over the course of the next 3 years or so, probably less time, 2 years, we'll be installing a new hospital information system. So this very old technology that we're currently using to run the place is going to be changed over. And so I know even just this week we've been asking physicians to help us for some guidance around which direction we should go in that regard. So hopefully you had a chance to participate in that. If not, still further chances. I think in June we'll be making a recommendation to our board. Do we upgrade our Meditech system, or do we go down another path with Epic or some other software provider? At the same time, we're also on the cusp of investing very significantly both in terms of new diagnostic imaging equipment, a new approach to diagnostic imaging across the whole of the hospital, as well as very significant investments in new capital equipment over the next couple of years. So Michael can speak more to this, but we do, again, I think we see physicians as critical to helping us to invest all of those dollars wisely. So maybe I'll end there. I'll pass it over to Michael, but again, I wanted to say thanks very much for all that you're doing. We're very grateful for all of the physicians working here at Hamilton Health Sciences, for all the important work that gets done for our patients. And cheers. Hope you're doing well otherwise. Michael, over to you.
Sure. Thanks, Rob. And I guess I would just like to echo Rob's words and thank you all for your contributions to the organisation. Not simply just with the patient care that you deliver and the way that you manage very professionally all the patients that you deal with, but also your other contributions in the organisation, because they're very important for the smooth running of the organisation, the efficient way that things are done. And without the input that all of you have, it would be much more challenging for us to keep this place functioning as well as it does. And I think for that we're very grateful and thankful, and Doctor's Day is an opportunity to celebrate that. So I know you've had your coffee this morning, but if you go to one of our coffee outlets, they'll give you a free coffee today. So make sure you avail yourself of that. And there are some cards that also over the whole month will offer you a free coffee as well. So that's just a very simple thing that we're doing. To echo Rob's words again, I mean, it's a really exciting time for Hamilton Health Sciences. I mean, there are a lot of really good things happening in the organisation in the next few years with the capital equipment that Rob's talked about. And I think as physicians, one of the really important things for us is the upgrade of the hospital information system with the new electronic medical record. I think you've all lived with what is now relatively ancient technology, which functions, but there are many problems with it. And I think we're all looking forward to getting some new tools to help us to manage with our patients. But part of that will mean we need really good input from you and to assess the various platforms that we'll look at. So That'll be an initial step where that feedback from you will be very important to help us guide us as to which way we go. But once we've made that decision, there'll be an implementation process, which again will be really a way of trying to streamline that electronic platform for your own individual services. So every service is a little bit different, and they're relatively flexible to enable that to be streamlined so that you can create an entry page that gives you a lot of the information that you need. So it'll be very important that all of you have some input into that through your department. I think at this stage I'll probably just leave it at that for now, and I think Rob and I are happy to answer any questions if you have any that you'd like to ask us before you get underway with your talk. And it's the second day in a row I'm seeing PJ. So any questions anyone has? No? Okay. Very good. PJ, yeah.
Obviously you're thinking about this. I think one of the things that will end up being crucial is that whatever system we go with, we're able to share with St. Joe's, just because a lot of times we have patients coming between the two sites, and there's endless challenges right now because it's not as simple to access Epic when they're here, and that leads to some misinformation around patients.
Yeah, and I think that's a very good point, PJ. And I think one of the critical things with whatever electronic record we get is that there will be an easy connection to the information at St. Joe's. And one of the good things with this whole project is we have Barry Lum, who many of you know, sort of being the executive lead on that. And so Barry is familiar with Epic. He understands the need for that, and I think it's one of the key things that he and Rob Lloyd and the team will be ensuring there is. So even if we choose a provider that's not Epic, the key thing is there's got to be a very simple access into the information in Epic. We've seen it in Orlando earlier this year, and certainly the new Meditech platform does have a single click into Epic, so you can get into that without having to navigate, multiple positions. But whether that's sufficient and adequate, I think, will be a thing for those who look at the systems to determine. So you're absolutely right. I mean, to have discordant systems within the community that you can't easily access will be frustrating for people. So that's an important piece. Yeah. Okay. Thank you very much. Thank you for allowing us to come and say hello to everyone and enjoy Doctor's Day. Thank you.
Okay, so I'm just going to introduce our two guest speakers, Dr. P.J. Devereaux and Dr. Emily Bellay-Cote. So Dr. Devereaux is the director of the Division of Cardiology at McMaster University and the scientific leader of the Anesthesiology Perioperative Medicine Surgical Research Group at the Population Health Research Institute. He's a full professor and university scholar in the Department of Health Research Methods, Evidence and Impact and Medicine at McMaster University. And his focus in his clinical research is vascular complications around the time of surgery. He's undertaking several large international RCTs and has been a prolific academic and researcher in this area, having published over 300 peer-reviewed papers and over 60 book chapters and editorials. Dr. Bellay-Cote obtained her MD at the Université de Sherbrooke. She completed her internal medicine cardiology training as well as a Master's of Science in Clinical Sciences. Following that, she completed the Critical Care Fellowship at McMaster University and is currently in her final year of her clinician investigator program and PhD in clinical epidemiology here. And the focus of her research is to improve the short and long-term outcomes of patients undergoing cardiac surgery. So without further ado, thank you very much for making the time for us, and please come up stage.
Thanks, Anne, and thanks very much for the opportunity to present here today. So, as part of my disclosures, I'm a member of a research group which is a policy of not accepting money for own direct personal financial gain. We will, however, take as much money as we can humanly get from industry to support research endeavors. And based on questions. I've originated grants. I've received grants from many different companies, and I've participated in a number of advisory committee meetings. So the goal of the presentation is to first understand when and where surgical complications occur, and learn about historical perspective on major paradigm shifts that have improved surgical safety, and become informed about the new division of perioperative care, which will be officially started as of July 1st of this year. So I want to start off with a case. So this is a case from the Jarovinsky. This is an 83-year-old female who had a history of hypertension and a 20-pack year history of smoking, but had stopped smoking 30 years previously. She had no known history of coronary artery disease, cerebral vascular disease, or peripheral arterial disease, and her preoperative ejection fraction was known to be 60%. She had a rectovaginal fistula. Of her antihypertensive medication, she took her Candesart in the morning of her surgery, and on February 7th, she underwent a lower anterior resection, loop ileostomy, and a vaginal wall resection. It was a late case. It went from 1825 to 2200. Intraoperatively, her systolic blood pressure was 80 for 10 minutes, and systolic pressure was 90 for 20 minutes. Post-op, she had an epidural in and an IV running at 125 cc's an hour. After her surgery, when she arrived on the surgical floor, her vitals were noted for the first time in the record, and at 2300, her heart rate was 91 and her blood pressure was 110 on 55. The next time the vitals will be noted to be checked in the medical record was at 4 a.m., so 5 hours later. At that point, the heart rate was 84 and the blood pressure was now 78 on 40. The surgical resident was called and he ordered 500 cc bolus of normal saline. The surgery resident was just going into the OR at this time. At 6:30, the vitals were next recorded to have been checked again. BP was now 70 on 38, heart rate was 76. The surgery resident was called again. They're in the OR. They said they'd be up as soon as the case was done. At 8 o'clock, the surgical resident arrives on the floor. The heart rate is 80. Systolic blood pressure is 75 on 36. They had ordered a hemoglobin at 6:30. It came back at 94, and the surgery resident ordered a unit of blood and an ECG. This was the preoperative ECG, so nothing very remarkable. Borderline criteria for LVH, but nothing very dramatic. This was the ECG when it was ordered, so you now see a QS pattern, V1, V2, V3. You see ST depression, V3 through to V6, and looks like a very concerning ECG. At 10:30, the systolic blood pressure was now 60. A code was called. The patient was admitted to CCU, inotropes fluids, BP normalized, troponins elevated. The next day, chest discomfort, 20 minutes, went to the cath lab, 85% mid-LAD lesion, had a bare metal stent, and had an okay outcome. Now, it is good news that it was an okay outcome, but obviously it could have went in a different direction, and it certainly highlights where I think we have holes in our system where ideally we wouldn't have got this far down the path of first identifying the problem and being more adept at quickly correcting the problem. So, globally, there's over 230 million adults having major surgery every year. So there's a very large population and it continues to grow. We have a paper that's just about to come out from Vision where we looked at 40,000 patients, global context, representative sample of people having non-cardiac surgery. 1.8% of adults age 45 or greater having in-hospital non-cardiac surgery were dead within 30 days. In Western countries, including Canada, that was 1.1%. But even at 1.1%, in North America and the U.S., this actually would make it the third leading cause of death if surgical mortality was made its own category of death. And there's another paper that was just recently published in The Lancet that actually came to the same conclusions looking at global data also. What is very telling, I think, about the Vision data coming out is that of the people who died, only 5, that is 0.7% of the deaths, occurred when patients were in the OR. And one could argue that surgery should be the most vulnerable period, is when surgery is happening, is when patients are under anesthetic. But remarkably, it is now by far and away the safest period of the perioperative setting of the first 30 days.
70% of patients who were going to die, died during the index hospitalization after surgery. And equally important, 29% of people who would die in the first 30 days died after discharge home, and obviously no one is sent home to die. Obviously this is unappreciated that other complications haven't yet happened or they're missed, and unfortunately things go wrong. In a global context, 6% of patients are readmitted to the hospital within a 30-day period, once again at substantial cost to our system and obviously inconvenience and morbidity for patients in terms of what they end up experiencing. Some of them will not survive it. This shows you the so this is from the VISION data where we're risk adjusting for preoperative and surgical variables, and we're adjusting for all postoperative complications because we want to know what postoperative complications are independently associated with death to understand what things are likely driving death the most. What is the most, so the second column shows you the number of people who would end up dying, the adjusted hazard ratio, and the final column is the attributable fraction. The attributable fraction takes into account how common a risk factor is and the strength of association to mortality to tell you what proportion of the deaths is this likely accounting for that you actually see here. Because sometimes, and to give you the example, if you look down at VTE, if you get a pulmonary embolism after surgery, it does increase your risk that you can die. The reality is pulmonary embolism in today's world after surgery is actually very uncommon, and so the attributable fraction for what accounts for overall consequences of the deaths that happen in the first 30 days is less than 1%. Whereas if you look at major bleeding, if you look at myocardial injury after non-cardiac surgery, if you look at sepsis, those things drive where the dominant cause of mortality, accounting for over 45% of the actual deaths in the first 30-day period. I'll offer you my perspective from an historical view of reading a lot of books around surgery and also books around anesthesia. And I put forward that surgical research has overwhelmingly focused on the intraoperative period, which has been really important and has led to a lot of very important advances. However, I do believe that so far there's been two essential paradigm shifts that have substantially improved surgical outcomes. Now I want to be clear about a point. There's been all kinds of advances within individual surgeries that have actually been very profound. But at a global level, what things have actually improved overall surgical endpoints? And I put forward to you that there's two, I think, that are most compelling at the moment. The first was the introduction of the sterile technique. So Joseph Lister and folks in the 1840s were on the cusp of actually, really being focused on the issue of sepsis. And, the books on this is so fascinating, what people thought at the time and what they were doing, and people just discovering from washing hands. And then Pasteur at the time, people still didn't know what microbes were and how this whole movement came around to really realize a substantial improvement could be made by introducing sterile techniques. And then obviously antibiotics followed, and this improved the overall safety in the setting. So surgical mortality in a number of studies show we're able to drop from 46% to 15% with basic sterile techniques. The second thing, and I'm not saying this because I'm talking to you today, but I think is actually very real. So the second thing that I think has been a paradigm shift is the introduction of anesthesiologists. And it's very interesting reading the books that exist before anesthesiologists actually occurred. So many of them would talk about putting people in 4-point restraints, and surgeons had to be incredibly quick to saw off a leg or something. And the details of what they did sound completely crazy, what happened to these poor people. But I think, and I'll get more into it in a second, that I think anesthesiology ended up having a very profound impact on improving overall safety. Also, I put forward to you that the story of anesthesia, in terms of how did it improve outcomes is really crucial because I think it actually offers insights into how can we make the next potential paradigm shift. So research certainly suggests that 100 years ago, that about 1 in 1,500 patients died intraoperatively in the recovery room from an anesthetic-related complication. And 100 years ago, most people having surgery were relatively young with very little comorbidity. In today's world, research supports that 1 in 200,000 people die from an anesthetic-related complication, despite the fact that in today's world, much older population with lots of comorbidity. So if anything, one would have just expected, based on the patient populations, for it to have gone in the opposite direction. But there's been this profound advancement in terms of improving overall intraoperative mortality and outcomes and anesthetic-related complications. So how did anesthesiology improve these outcomes? Well, I think like most things, it's probably multifactorial, but I do believe there's at least two very clear things that played a very important role. One thing was having a physician who was present and dedicated and responsible for the patient's physiological stability. And the second thing, I believe, is monitoring. And I think the combination of those two things is what has allowed for a dramatic improvement in terms of outcomes, because, once again, anesthesiologists were actually becoming very commonplace 100 years ago, but yet we still saw this enormous leap, and what was part of that leap, I do believe, was intraoperative monitoring. Now, some people will argue the evidence from RCTs that said, hey, this monitoring in the OR settings improved outcomes, very limited data in terms of the monitoring. But the simple litmus test is to ask yourself as an anesthesiologist, if you ever had to have major surgery, would you undergo surgery and tell people to turn off the monitors and use the force and try to get you through the case? And I suspect not many people are going to be enthusiastic about that approach, because it is so obvious that the monitoring is helpful to you, commonly in your daily practice. What is the reality about postoperative care? So in hospital, patients are usually cared for primarily by the surgeon, and obviously surgeons are doing what they love doing. They're often busy doing surgery the next day or the day after. And after discharge, patients are usually seen between 3 to 6 weeks later by a physician. What is the reality of monitoring after people leave ORs? Obviously, there's a very select few that go to critical care settings, and obviously they get intense monitoring there, but the vast majority of people are not going to that setting. And so in hospital, patients typically have their vital signs checked every 6 hours in our research, and a lot of times it's not uncommon it's every 8 hours. In the case I just showed you, certainly in terms of what was recorded, we had a 5-hour window between the first measurement and the second measurement of when the patient had become significantly hypotensive. And after discharge, patients are only monitored when they're actually seen in their next follow-up visit. So, a study that we undertook, we had just over 800 patients who were on surgical floors after non-cardiac surgery. We had a black box measuring a number of vital signs in these patients that was blinded, so healthcare providers didn't know the results that it was actually acquiring. In routine care of these 800 plus patients, the nurses said 5% of the patients became hypoxic on the surgical floor. Among the 95% of patients that the nurses said were not hypoxic, we then looked at what did the SAT data actually show on these patients. And this was continuous oximetry on these patients. 38% of the patients had at least one continuous episode where their SAT was less than 90% for at least 1 hour in duration, and 10% had a SAT less than 85% that was once again at that level for at least a continuous duration of 1 hour. Now, once again, if you're 46 with really good protoplasm, you may be okay with that. But obviously there's many patients with those kind of levels of hypoxia who don't have great protoplasm, and it's going to lead to potential complications for these patients. Dan Sessler and his group just published a paper in anesthesiology for the first time looking at the Sotera continuous blood pressure monitoring device on just over 300 patients at the Cleveland Clinic who had abdominal surgery. And at the Cleveland Clinic, it is quite striking in our research, they have much more frequent measurement of vital signs on their surgical floors. It's done routinely every 4 hours. That is not the reality within our own system. And so what they did was they put the Sotera machine on, which continuously measures blood pressures, and they had it on these patients for 48 hours. So the continuous blood pressure monitor on the surgical floor identified that 24% of patients had a MAP less than 70 for at least 30 minutes, and 21% of these cases were never detected by routine monitoring, even at 4-hour intervals. 16% of the patients had a MAP less than 70% for at least 60 minutes. 14% of patients had a MAP less than 65 for at least 30 minutes. 18% of the MAP less than 65 for at least 15 minutes. And essentially almost half of these cases were not identified based on routine clinical care when you're even doing it every 4 hours. We also have data that shows us that patients who get injuries to the heart after surgery substantially change their outcomes. So this is from the VISION study looking at high-sensitive troponin T. In this analysis, we're risk adjusting for preoperative and surgical variables, and we're exploring at what peak threshold of troponin after surgery do you alter the probability of patients dying at 30 days. And prior to undertaking this, so one thing you may or may not be aware of, there's one troponin T that's a high-sensitive assay. There's over a dozen troponin I assays. They don't have similar values. And so the way that laboratory medicine has dealt with that is that they just said, we'll take people age 40 to 50, healthy, happy, measure troponin, 99th percentile and above is what is abnormal. Now, obviously, that makes an assumption that nature knew we were going to use the 99 percentile, and it should be that that would be a very important deflection point in terms of prognosis. But obviously, that is a bit of a wish to know that nature would know we would focus on the 99 percentile. So we wanted to avoid making an assumption, but have a big enough study where we could actually allow the data to inform us where can we reasonably confident that, in fact, at this threshold, the probability from a prognostic point of view, and we focused on mortality, is shifting, that we want to focus on this. And so a priori, we made a decision that the adjusted hazard ratio for the troponin, in order for us to believe it is significant, would have to be threefold or greater and have an absolute risk of death of 3% or greater, with the underlying assumption that 1% of people were going to die in the first 30 days after surgery. What we found is that labs will tell you that 14, which is the 99 percentile, is what's abnormal, anything above 14. What we found was that less than 5 appeared to be what was truly normal. And if your peak troponin after surgery is less than 5, your likelihood of death in 30 days is 1 in 1,000. The next threshold we found was 5 to less than 14. It met our adjusted hazard ratio, so it was over a threefold increase in the probability of death at 30 days. However, the absolute risk of death was only 0.5%. It didn't meet our absolute risk of death threshold that we had a priori defined of 3%. 14 to less than 20 was the next threshold we established. 9-fold increase in the probability of death after adjustment for preoperative and surgical variables. But once again, the absolute risk of death did not meet our criteria. It was still 1%. Once we hit 20 to less than 65, the next threshold we identified, we now hit a 3% absolute risk of death. The adjusted hazard ratio was over 23. 65 to less than 1,000 was the next threshold we established. You're now up to an absolute risk of death of 9% at 30 days. The adjusted hazard ratio is 70. And if your troponin gets 1,000 or greater, your likelihood of death now in 30 days is almost 1 in 3. It's 30%. And the adjusted hazard ratio is over 200. Now, regarding these events, 93% of the events of these myocardial injuries after non-cardiac surgery occurred without ischemic symptoms. They overwhelmingly happen in the first 36 hours after surgery when most patients are getting analgesic medication that can mask ischemic symptoms, and if you don't measure the troponins, you will miss the events. And these elevated troponins that did not have any ECG changes or ischemic symptoms, after excluding evidence of non-ischemic etiologies like pulmonary embolism, sepsis, etc., these events substantially independently alter the probability patients are going to die in a 30-day period. So because a patient doesn't have symptoms does not mean the event is benign. These patients actually remain at high risk of having recurrent events that they die from. We've also demonstrated that, in fact, you can treat these myocardial injuries after non-cardiac surgery and improve outcomes. So this is the MANAGE trial, which we published last year in The Lancet. So we randomized 1,754 patients who had myocardial injury after non-cardiac surgery to get dabigatran 110 milligrams BID or placebo, and we showed that dabigatran lowered the risk of major vascular complications in the coming 2 years. 3 points to note from these actual data of these Kaplan-Meier curves. The first thing is that the highest risk period, the most accelerated event rates, happen in the first 2 weeks after MINS. Most people die and get into serious trouble with recurrent events. So in the placebo group, you have a 5% incidence in the first 2 weeks of another recurrent major vascular event. The two curves separate immediately between dabigatran and placebo. They continue to divide until 1 year after surgery and then remain parallel out to 2 years. Moreover, at 2 years, the curves have not obviously plateaued. Now, they may plateau at 2 years. That's not clear to us, but it's not obvious that they've actually plateaued. Moreover, if you put these data besides the big clinical trials that are coming out now and treating patients who have prior heart attacks, known peripheral arterial disease, the patients who get myocardial injury after non-cardiac surgery have 2 to 5-fold higher event rates for major vascular events in our trial compared to what is being seen in the large MI and peripheral arterial disease trials. Just once again highlighting these patients remain at very high risk for recurrent events and end up doing poorly in the intermediate term. I put forward to you that there's also many missed opportunities in the surgical setting. So smoking cessation. So envision 18% of patients having surgery are smokers. Global context. In terms of what patients will even tell us, 50% have resumed smoking within a 30-day period. In our research, trivial numbers of patients get nicotine replacement prior to surgery, and very few are getting it in the post-operative setting. And there is strong evidence that if you give people nicotine replacement in these settings, you will increase the likelihood of being absence from smoking at the time of surgery, but even 1 year after surgery. Just advice itself helps to get abstinence around the time of surgery, but the trials really suggest you want advice plus nicotine replacement if you want to have a hope of getting sustained abstinence from smoking. We have a need to continue interoperative research. So, even though the majority of research has happened there, the majority of events I put forward to you that are actually now what's wrong with perioperative care is postoperatively. But at the same time, of course, we should still keep pushing to make advances intraoperatively. We need to implement what is known, and we have to have willingness to reevaluate structural issues, which we're going to get into, and we have to be willing to be disruptive in terms of changing the way that we currently organize ourselves to provide perioperative care. I think we should learn from this story of anesthesiology. I do believe that, in fact, the primary thing I think that is wrong today with perioperative care, where the evidence leaps off the page of what is wrong, is postoperative care. And I think what is suggestive is that the problem is we have people that are not, the people that are managing them are obviously busy. They're doing other things. They're not readily available to manage cases. And secondly, we have a system of really suboptimal monitoring of our patients. So a new perioperative care service that is dedicated and available to co-manage patients with surgeons after surgery on the surgical floor, but importantly into the home setting. And remote automated non-invasive monitoring is what we believe these two factors may be allowing us to really improve postoperative events. So there's a trial that we're doing right now called SmartView. It's a randomized control trial of 800 patients. We're almost halfway through it. So these are patients undergoing cardiac and vascular surgery. And so when patients, the intervention, you either get normal postoperative care with normal monitoring, or you get our intervention, which is the Philips Remote Automated Monitoring System with alerts and monitoring into the home setting. The primary endpoint for this is hospital readmission after ER or ER visits. So in hospital, patients have this device put on which gives us continuous oxygen saturation, heart rate, respiratory rate, blood pressure, which is an inflatable cuff, which is actually a problem. This technology will not be what is used for the future, but this is proof of concept. This goes off every 2 hours during the day and every 4 hours at night. And there's built-in alerts based on patterns seen that then step up care to these patients more quickly than what can happen just with normal care. When patients go home, they take a tablet. We interact with the patient every day. We look at their wound. There's questionnaires they fill out. We get their temperature. We get their blood pressure several times a day. We get their weight, and we get their heart rate and SAT several times a day based on the look of the wound or any of these parameters, and that just leads to stepped-up care for these patients that we hope can lead to identifying problems earlier, preventing hospital readmissions, and preventing catastrophic events. Where the future, I think, will go, and this is what we'll be using for Vision 2 and for Poise 4, this device right here is the tricorder from CloudDX. So this device can give you continuous non-invasive heart rate, blood pressure, heart rhythm, oxygen saturation, temperature, respiratory rate, movement, body positions, sleep analyses, and steps. I don't know if it'll be this monitor that will win. I suspect it'll be many monitors, but it's going to be a monitor like this that is actually, I believe, going to change us. They've also redesigned it so we can now get a 5-lead ECG continuously on these. You can take this monitor home. People can wear this for a 30-day period. Once again, our goal within Vision 2 is we're working with IBM and Microsoft and trying to use AI to actually understand the patterns with the interaction of all these variables at once to know who is showing early signs that they're heading into trouble. Now, there's some easy things that if a patient just goes into VT or rapid AFib at 180, you need to know nothing else. But a lot of patients, it's patterns of actually what's happening with multiple biophysical parameters at once that tell you someone is going in the wrong direction, preceding myocardial ischemia, infection, sepsis, these events that drive bad outcomes. So we're looking at, as of July 1st, we will have a perioperative division. It will be multidisciplinary, anesthesia, medicine, surgery, and nursing. We will, from the clinical side, so the academic side, we're going to house this in the Department of HEI. The reason for doing that was that there was meetings of the chairs of anesthesia, surgery, medicine, and HEI. I advocated to put it in HEI because I don't want it to go, I worry that if it goes to medicine, people will then view in anesthesia and surgery that it's not theirs, and or vice versa. And we want it to be that all groups need to play a role in terms of figuring out how we're going to do a better job in postoperative management. And we're hoping, and Emily will talk about this in a moment, that in fact anesthesiologists will also consider being part of the postoperative services. No one has to, but the service will benefit from anesthesiologists being part of that. Once again, your main job will be an anesthesiologist, but we're sorting out, we figure that it has to be a minimum of 4, maybe 6 weeks a year that one would have to participate in this. So people who have previously considered doing critical care but want to be involved with that, to be involved with this type of care. And we also have experience from both SmartView, but also we've created rapid assessment clinics after people get myocardial injury after non-cardiac surgery or atrial fibrillation. We see people in 5 to 7 days after surgery. And the one thing from both SmartView and those clinics that's very striking to me, there's endless drug reconciliation problems with patients who go home. It almost seems to me that it's actually the norm, that in fact drugs get screwed up all the time, which I think are one factor contributing to readmissions and complications. There's also this issue that a lot of patients on a surgical floor, and because the push is to send people home sooner and sooner, and that's not going to disappear, in doing that, you have a lot of times you have an older patient who's been on 4 antihypertensives, and post-operatively their blood pressure is like 105 systolic, and people worry that if they don't put back on these medications, they'll never get restarted. And so people get piled on these medications and then sent home. And some of those patients aren't able to tolerate those medications. But by having a system where, in fact, we can rapidly see patients post and we can transition them into the home setting, we don't have to pile everything on. We can start what is reasonable and going to be physiologically acceptable to the patient at this time, and then see them in short order to then appropriately titrate up as the patient can tolerate. But we need to just have more people involved in postoperative care, because a lot of medicine and cardiology is focused on preoperative care. In preoperative care, yes, there may be some value in it, but the problems are happening after surgery. If we only have so much resource, our focus should go to postoperative care, because that's where the actual action is. Yes, and we're going to have a phased-in approach, like across surgical units. Emily's going to tell you from the clinical service part of view, the first step that we've actually done in this. So my takeaway messages are: patients undergo surgery for important reasons. We should never lose sight of that. We want to make it so that it's safe for everyone at any age. They can safely have surgery. We need to improve surgical outcomes to a point where it can be worry-free. We need to implement what we know and avoid missed opportunities and conduct more research. We should learn from the history of anesthesia to apply that framework to postoperative care. There's a need for new physician care services after surgery and into the home setting with remote automated non-invasive monitoring technology. And this has the potential, but it needs to be proven. Could it represent a third paradigm shift to really improve surgical safety? Remains to be determined, but we want to explore that. So with that, I'm going to turn over to Emily.
Hi. Hi, I'm pretty excited to tell you about the shared care model we've implemented on 5 South. So that's the post-cardiac surgery ward at the General. And so there are sometimes misconceptions with what we aim to achieve with the shared care model. So we don't aim for surgeons to spend less time in the OR and more time on the golf course. We aim for surgeons to be able to do their job, which is operating, without having to also think about their patient's need on the ward at the same time. But ultimately, what we really want is optimal patient outcomes. The goal of this shared care model, which involves peri-op specialists, and that's a new term we've come up with, and this group is a very multidisciplinary group with anesthetists, internal medicine specialists. I would love to have surgeons involved. And our short-term specific objectives are to ensure that pre-op patients are optimized, to expedite appropriate consultations and investigations in patients after surgery, to improve adherence to evidence-based practices, to facilitate the flow of the unit by increased physician presence, and to facilitate post-discharge follow-up, ensuring everyone has a cardiologist. If they need an ID follow-up, they have an ID follow-up. We also have long-term objectives of this shared care model, which will involve increased patient information on expected recovery, implementation of an early post-discharge follow-up clinic. We hope to reduce hospital readmissions. We hope to build a sustainable research and quality improvement platform, and we aim to enhance medical education for residents. The reality is, in the community, these post-cardiac surgery patients are repatriated to their centers, and they're under internal medicine specialists or cardiologists who may or may not have had exposure to post-cardiac surgery patients in their training. So from a practical standpoint, how does it work? So we have a peri-op team that will at some point be composed of between 7 and 14 physicians. We have hired 2 physician assistants who help run the unit. The peri-op team offers rounds 7 days a week and cover the unit between 7 in the morning and 5 at night. Some people may raise concerns initially that the surgeons would forget how to manage their patients and that their residents would not get appropriate training. However, surgeons are heavily involved in their patient care. They round on their patients daily in the acute phase. They review their patients daily with the peri-op team. They offer procedural support. So if there's a need for a TAP, a chest tube, the surgeons are around and expected to help. They are to be responsive if we want to discuss any issue with them. And between 5 p.m. and 7 in the morning, the coverage goes back to the surgical team. So the current status, so we've launched the model on Friday, April 5th. So we're like almost a month in the model. Currently, we have 7 peri-op specialists. So 2 cardiologists, 1 nephrologist, 1 endocrinologist, 1 internist, 1 anesthetist, and 1 hospitalist. The 2 physician assistants, I put their pictures because if you go on FIVESAT to do pre-op consults, you may see them. You can say hi and say, oh, I know you. So far, everyone seems very happy with the model. The flow of the unit has been excellent. However, we will formally, ongoingly assess how things are running. So for the first 6 months, we have monthly meetings with key stakeholders. So our first meeting is tomorrow, and we'll sit down with the peri-op specialists, the physician assistants, the unit manager, the chief of cardiac surgery, and see what have been the big wins in the first month, where can we improve. After 6 months, we'll start assessing length of stay and readmissions to see if we're having an impact on these important outcomes. And if we see numbers going in the wrong direction, readjust what we're doing to ensure that we impact patients positively. So this shared peri-op care model, I think will improve cardiac surgical outcomes, and they can be improved, especially readmissions. I didn't show these numbers, but the readmission after cardiac surgery is around 15% at 30 days. So it's a huge number of patients. Also improve medical optimization. Up to 15% of patients leave the hospital after CABG surgery, not on a statin currently. So that's something that can be improved as well. Having dedicated physicians is for sure part of the solution. They can provide a rapid response if there's a problem, and their whole focus is on medical optimization. So this is the beginning of a new era, and hopefully over the next months and years, we can spread this model to other surgical services. There's definitely been an appetite for that. I've had calls from other cardiac surgery centers inquiring how we were doing this and asking if I could share what I had so far so that they could inquire with within their hospitals if there was an appetite for that. Also, I think locally other people have reached a PJ inquiring about implementing such a shared model for other surgical services. So I think at this point we should probably take questions and comments.
Yes.
Thank you very much. Very good initiative. I think it's all over good. One of the questions I had for Dr. Andy is the night coverage.
Yep.
The surgery?
Yeah, so at night the coverage goes back to surgery. So what we're working is on implementing a good handover system. So for now there's a lot of unofficial communications over WhatsApp, text, just like phone calls, like handing over what the main issues are. But the physician assistants are working on a handover list. Where there would be enough information for the residents and the surgeons to know the patients, and also like a list of ongoing issues and things to monitor overnight. Yeah, so at night they would be doing the same job.
But just, yeah, I mean, it's like everything that you implement. I think that the ideal goal is to get to a place where it is 24-hour-a-day service. Like anything, though, we're not going to offer something unless we know we can deliver on it first. And at the moment, to have one physician on for the week who's going to be covering the entire nights on some surgical services like the cardiac surgical service, we just think is not possible. That is our goal to get there. So we do appreciate that, like the models we're starting with, it's organic. This is not what we think is the final model. We think it's the first, hopefully right step, but we do appreciate the point you're raising, which I think is very legitimate, that ideally we need to make sure that we're providing excellent care also after hours. Right now we're doing it 7 days a week during the workday, but the goal will be to get to 24 hours a day. Yes, Arsha?
With regards to this model as generalizing it to all surgical groups, is there a process to include all patients, or is there a process to include high-risk patients? And when do the patients actually get to know the team? I mean, for them, it's always the surgeon, he's going to do the job, and then I go home. So when do they actually, I know cardiac surgery is probably very different because they're all high-risk patients, high-risk surgeries. But in the bigger scheme of things, when it comes to other surgeries,
Arsha, it'll be determined with each surgical group how that's going to play out. So the point is first to start with that cardiac surgery, all cardiac surgery patients are high risk. Yes, but just to make the point that in Hamilton, there's other surgical services that have actually higher mortality rates and actual complication rates. One of the things that has actually really helped cardiac surgery and has really brought down, I believe, their mortality rates and improved things, everyone now goes to a critical care setting and then when felt to be stable goes out. And that you don't have that model, that model just doesn't exist for any other surgical group. And I think that's part of, once again, the same message that we're saying. We think it's suboptimal monitoring and people not being available. Our plan is, once again, in a rolled out process, starting with certain surgical, non-surgical, non-cardiac surgery groups, implementing this. And we'll have to work through the process. We do think that, for the non-cardiac surgery system, patients will, whatever that service is, they will be seen pre. The main reason to see them pre is occasionally, but it's occasionally you pick up someone who has critical AS that no one knew about. But that is extremely uncommon. It's mainly to know who the patient is so that when we take them over immediately post-op or we're doing shared care with them, we know who the patient is. And so then we do this. Now, in terms of the monitoring strategies, in terms of who's going to get remote automated non-invasive monitoring into the home setting, a lot of research will have to be done to figure out it's not true that everyone needs that. At the same time, it'll be figured out from, just an effectiveness and cost effectiveness point of view, which patients have the most potential to benefit from that. So still a lot of work to sort out what each one will look like with each specific non-cardiac surgery, but it'll be organic and it'll be determined with the surgical groups.
Sorry, just one question on that. You did mention that they'll be seen pre-op.
Non-cardiac surgery patients.
Non-cardiac surgeries. Would that mean they'll be seen by a physician, like other than anesthetist, or is that any member of the patient team?
Yeah, so right now, as an example, take the Jarovinsky, where we have, I'll use orthopedic patients, they're seen by internal medicine. If they have any cardiovascular risk, and then also refer to the cardiovascular service. We want to try to streamline the process, so everyone on the medicine side is collapsing into one. So in fact, we're trying to make it simpler and less, challenging for patients with seeing a bunch of people pre. But once again, that's only being seen because if we're going to co-manage posts, we want someone, who actually has seen our patient, our team, who actually has known the patient, and the information's in there. But one of the things, there'll be meetings coming up starting first on the HHS side with Leslie Gauthier, trying to rethink just the whole preoperative setting too. Like, what is the best structure that we should have? So while we're in a process of creating a division, rethinking this, and there's, initiatives being invested into actually trying to improve this, maybe we can reimagine the whole structure of what might be more optimal for our patients. And as I said, I personally think a lot less should go into pre-op and a ton more should go into post-op if we say we've got a resource allocation problem. Yes.
So I'm the director of the acute pain and regional program at St. Joe's. And one of the things I've thought about a lot, and I'll put this in the framework of the HIPATAC site, is I think that what's going on with those hip fracture patients is that there's a diagnostic dilemma that happens in the days that they're waiting for their surgery, where they're in tremendous pain, which puts up their heart rate and their blood pressure into the normal range, when it probably would be in the hypovolemic range if they weren't in so much pain. And so and the reason that I think that this is going on is because emergency physicians have started doing fascial ACA blocks. And when those patients come, they're completely different. They've been adequately resuscitated. They're not in pain. They haven't received anywhere near as much in the way of opioids perioperatively. And I think they'd probably do better. what's going to be the role of regional anesthesia in the realm of this perioperative group and trying to
Yeah,
help
so
these patients and maybe decrease the diagnostic dilemma?
yeah. So one of the things I want to emphasize again, we say this sincerely, we hope anesthesia also perceives that this new division is their division too. It's not meant to be a medical division. It will not achieve the success I think it could achieve if in fact it ends up being just simply based from a medical perspective. So I hope you'll consider being part of that, bringing things forward and saying how might we improve these things. Because I think the thing is, everyone, you have knowledge that clearly we don't have in medicine, that understanding pain and blocks and all these things at a level that we have pedestrian knowledge about. I think it's when the groups come together to sort out how to better inform those pathways, we have the potential to make advances. So please bring that forward and be part of what we're trying to sort out. Hip attack is about to finish. We'll hit 3,000 patients in the next couple of weeks. We'll see whether or not accelerated surgery matters. The one thing that is clear from still hip attack is these patients have terrible outcomes. So even if hip attack works, it's only a first step. And perhaps, in fact, there's other solutions that may be, in fact, even more important that really could help to stabilize patients and have better outcomes. So we're hoping it'll be hip attack 2 and 3, and because these patients have bad outcomes, and I've not heard that argument before, and I think it'd be very interesting to explore it. But also, too, thinking about it, first we should be committed to doing research that whatever we try to put into the service we think is based on reasonable evidence. Until we have evidence, we're still going to act on what sounds rational and reasonable, but trying to get trials done to inform that, but also get the people that have the expertise to actually do this. So as an example, I'm heading to Ottawa. I'm going to do a couple of weeks in the pain service, trying to gain some beyond my basic pedestrian knowledge of pain, because we want to understand more how these things interact within this post-operative setting too, but also even pre-surgery.
What is the full complement and vision for the 5,000 physicians? How many physicians do you need?
I mean, right now with like 7 physicians, I can cover, but it's a bit fragile. Like if someone gets sick, I think like having between 10 and 12 people is probably optimal, especially because there's also other initiatives like the rapid follow-up clinic that we'd like to implement, and I think it would probably be too heavy to have someone take care of the inpatients and do that clinic. So having a bit more people would help be more robust and innovate further.
We sort of envision, Thomas, is that there'll likely be a person, I'll use non-cardiac surgery, there'll likely be a person who's doing both pre and post follow-ups, who's on the outpatient 1 week. There'll be a person running the inpatient, and you'll rotate between the two of them. And once again, for people to be part of it, which we really hope some anesthesiologists would want to be part of it, there'll be a certain commitment you'll have to do X number of weeks, because knowledge is content specific, and you got to be enough immersed in it to develop that expertise. But we definitely can benefit a lot from anesthetists and their perspectives and their background experience. And but we do think that there'll be both an inpatient and outpatient services to really make this work optimally. And as we advance the into the home monitoring, once again, that person who is on the outpatient service will be responsible for those patients on the outpatient setting with the monitoring.
Of the physicians that are involved in it, do they undergo specific training, or is this an area of interest?
Yeah, so far there hasn't been specific training. Like on their first week, I asked the cardiac surgery residents to be and the chief, like Iqbal right now, to be very involved, so that they first feel comfortable asking questions and reaching out if needed. But like most people doing the service right now are like freshly trained and very eager. So it hasn't been like a big need to have a specific training, but there's for sure, like in the first few days, especially for people who don't have critical care training, like a bit of information around like pulling wires and pigtails and things like that, but no formal training.
So we have had a perioperative vascular fellowship for, I don't know, at least 6 years that the CAS-10 has run. But certainly we hope, like vascular issues matter, but they're not the only thing that matters. So we hope that we will be developing through this. There's going to be a fellowship program that will actually be covering all of perioperative medicine that deals with everything that's involved. And we hope to make that eventually a Royal College fellowship program. it's a bit like anything when something starts, that when anesthesia first started, there was no anesthesia program because people were just figuring out what's going on. I don't want to say we're exactly at that stage, but we're not far off of it. So obviously, you know, as I said, people like myself have to go back and learn something about pain. The younger people, it's easier because in your training you have, you know, you're a lot closer to everything in terms of what happens. So we think that for people who are part of it that are coming in later, it depends on their background, what things they're going to have to brush up on. But for younger people, we will be working towards establishing a fellowship program, but there will be a fellowship program, but it won't be Royal College approved as of July 1st. And, you know, that'll exist for people that want to be part of it.
Maybe by the time you're done, Dylan, it will be Royal College approved.
Thanks very much.
Thank you.
Thank you very much.